So next topic is multinodular goiter. It's V27. A 56-year-old woman presents to your clinic with a large mass in the neck that she has had for several years. How would you assess her? This sounds like a multinodular goiter. I would take a history requiring the following symptoms: irritating cough, shortness of breath, stridor, hoarse voice, and pain due to infarction or hemorrhage into the cyst, dysphagia, rapid growth with indicate malignancy, previous head and neck irradiation at a young age, and family history of men. May be relevant if dominant dual. I would examine her assessing her thyroid status. Relevant features are the neck lump, whether there is a dominant nodule, cervical lymphadenopathy, and retrocell extension. I would take blood for thyroid function test, T4, TSH, range and ultrasound scan plus minus FNAC. If there was any evidence of retrocell extension and tracheal deviation compression, then I was planning surgery. I would ask for a CT scan of the neck to assess. What are the causes of multinodular goiter? Most due to the enlargement of the simple goiter, which developed due to the TSH stimulation secondary to a low level of the thyroid hormones, which could be iodine deficiency, increased demand for thyroid hormone during the puberty and pregnancy, dietary goitrogens, brassica vegetables, lithium and carbimazole reduce the goiters. Rare hereditary congenital defects in the thyroid are also cause goiters. Sporadic MNG can occur. Previous radiotherapy can. You find a dominant nodule in the left hand outside of the goiter. How would you assess it? So FNAC should be performed ideally under the ultrasound guidance. Ultrasonography may also be demonstrate enlarged lymph nodes. The use of the U1, U5 scoring system is recommended for assessing the risk of malignancy and FNAC, the thyroid nodules. Further management would then be dictated by the FNAC result, which would contain a descriptive section. Then, if cytology is malignant, oncology surgery should be planned. If cytology result is indeterminate, then diagnostic surgery should be performed. When would you offer surgery for a multinodular goiter? When there is suspicion or confirmation of malignancy, rapid growth, FNAC result, toxic multinodular goiter, patient with pressure effect like dysphagia, dyspnea, and stridor, and for cosmesis in patient with large neck swellings. What operation would you perform? For a multinodular goiter, I would do a total thyroidectomy. Prior to the surgery for MNG, I would ask my anesthetist opinion that this could be difficult airway. Lung function test with the flow loop studies and CT neck will evaluate the degree of airway compromise, external extension. So lung function test with flow loop studies and CT neck. Nutritional extension. The patient may need awake fiber optic intubation. Thank you. This was multinodular goiter.